Today, I have Dr. Marty Brodsky with us. He is going to be discussing reporting and the importance of standards in reporting. Dr. Brodsky, thank you so much for offering us your expertise today. To start things off, can you provide a summary of your clinical and research background for us?
Hi, Brooke. Nice to be with you, and thanks for the invitation.
Yeah.
So I started out as probably most people do as a clinician. I worked for 4 years prior to going back for my PhD. And within those 4 years, I was in inpatient and outpatient rehab. I was in acute care, and I worked in several different nursing homes, all of which were in the Detroit area. From there, after having spent 4 years clinically, I started my PhD. I did that at the University of Pittsburgh. Spent a lot of time in aphasia, actually, at the beginning of my doctoral degree, but certainly got into the stuff that I wanted to study, and that was dysphagia and all of its various things about swallowing. Commuted my sentence, if you will, during my PhD, and I worked with Dr. Bonnie Martin Harris at Medical University of South Carolina. Finished up my PhD. I had my first position in the Department of Otolaryngology, Head and Neck Surgery at MUSC. And following that, I spent about 15 years at Johns Hopkins University, where I left there 15 years hence with some funding from NIH, FDA, and now I'm at Cleveland Clinic and section head of speech pathology in the Head and Neck Institute. So it's been a wild ride, to say the least. It's been an enjoyable ride, and I would say that the predominance of my research right now is in ICU, critical care broadly, and taking a look at how airway and voice and swallowing are all disturbed in some way or affected in some way, probably a better way of saying it, than relative to critical care, and very specifically with regard to intubation, oral intubation, and nasal intubation, not tracheostomy. There are others in the field who study that topic, and I'm sticking with the big long tube for now.
Well, Dr. Brodsky, thank you for providing your background and just all that you do for the field. I know in my clinical work, because I also work clinically, I cite a lot of your research in my documentation. So very appreciative of everything that you've done for the field so far.
Thank you.
So with that, we'll go ahead and move into our topic for this webinar. So my first question for you is, many speech pathology teams are striving to improve their reporting processes, as you know. So from your perspective, why are standards in reporting for both MBS and FEES studies important?
I would even extend that for standards and reporting, period. We don't need to qualify it for instrumental exams. Standards are there for a reason. First and foremost, the medical record is a legal document. It states very specifically what was or was not done and what the findings were and the implications and everything else that goes with it, including diagnosis and prognosis, for any patient under the sun. It is something that is directly admissible in a court of law. It is something that you will be held to for whatever it is that you do. The standards I look at as a framework for getting the right stuff in the right places and in the right way. And that's it. This is not a creative writing assignment that we've had in an English course somewhere. This is follow the rules, do what you need to, get out. So the standards to that extent provide a framework for everybody to understand almost implicitly what is to be expected when I go looking into that specific document. I'm very certain anybody working in healthcare professions knows that when they get lab results back, they are very standardized. RBC, WBC, et cetera, all the way down. There's no different in our writing as well. There's an expectation for where to find things within our note. There's an expectation that in those places, we know what is to be expected in terms of what was written. So in this way, it's a framework, and it's something that everybody can use across the world, and is not specific to instrumental exams. Mm-hmm. Now, with that said, I think most people have some understanding and learned somewhere along the way the concept of a SOAP note. Whether it actually looks like a real SOAP note now, that's a whole nother debate. And I can tell you, I don't think I've seen a SOAP note in many years. I think the last time I saw it, dare I say, was when we were actually on paper rather than in an electronic medical chart. Sorry to show my age a little bit here, but I do remember writing on paper and NCR copies as well, for those who know what those are. It really is the same concept, though. What is it that the patient's complaining about? What is it that your assessment showed? How do you interpret your assessment? And now what are you going to do about it? Okay, that's the nuts and bolts. There's no creativity here. I know that if I'm looking for a test result, I'm going to look in the assessment portion of the note. I know that, there's 1,000 figures and numbers and Lord knows what else in that assessment. Now tell me what it means. I'm going to look in the assessment part. For anybody who's interested about what I'm going to do with the stuff that's bad, they're going to take a look at the plan. Okay. These are very high expectations that everybody has. And as long as we're following this kind of model, there isn't going to be, or at the very least, you're going to reduce risk of confusion for the reader first. And from your standpoint, it's going to make ease of writing a whole lot easier because it's a very well understood, very well organized system. What happened? How do you interpret it? What are you going to do about it? Those are the basics.
Definitely. And I couldn't agree with you more. I think standards are critical in all medical documentation. As you know, specifically for this webinar series, we're talking about modified barium swallow studies and really trying to help clinicians understand the process from start to finish. So with your expertise and using the information that you just gave us, what are your recommendations about what should potentially be included in that MBS report?
So I'll go back to the basics, I guess.
Okay.
For me personally, I approach an MBS, I hope similarly to everybody else. But it also kind of depends on the setting. So it sounds like I'm waxing and waning and waffling here. I'm really not. In an inpatient setting, most likely, no matter where you are, anywhere in the world, you're likely to have known that patient prior to the MBS. Because you would have known that patient prior to the MBS, you would have, by definition, done a typical clinical exam that would include a cranial nerve exam, among other things. Whether you tried something orally or not is immaterial. At the bare minimum, a cranial nerve exam is really contributory to understanding what's going on in the swallowing system. So that's on the inpatient side. And whether that's inpatient rehab, inpatient in terms of a nursing home, inpatient in terms of even a going to the person's home visit. Okay. Now I'm going to switch gears a little bit and go to the outpatient area. And there are varying practices here. My personal opinion is that, and once you get good at it, once you've done a few hundred of these, you can do a cranial nerve exam in the span of less than 5 minutes. There is no modified barium swallow study I have ever completed anywhere in my entire career without first knowing a cranial nerve exam results. So I would say anybody who's doing this exam, and this goes for fees as well, anybody who's doing an instrumental exam, how about if I broaden it? They need to know the cranial nerve exam results at a bare minimum, because interpretation of those results have to jive with what you're seeing on the modified barium swallow study. If you will, you're taking a look at the outside to take a look at the inside and understand both sides. Okay. So
Excellent.
to me, that is part A of two parts of a complete exam. Part B, of course, is the modified barium swallow study or any instrumental exam you might be doing. So that's the first issue. Second issue is there are many different parts that you should be writing. Among them, there should be documentation of who's in the room with you or who's reading it or something along those lines. You don't necessarily have to name that person by name. It's ideal, but you don't have to. And there's certainly no requirement in documentation anywhere that says you have to. I personally like to put the name of the radiologist who's with me and is joining me for the exam. Again, thinking back to medical legal documentation, this is the person who sadly might be drawn in with you in a subpoena or in a courtroom, and you're going to want to document this information to make sure. Now, again, that radiologist's note is likely to stand alone in most facilities, and they're going to be brought in anyway. Mine is a double check, if you will. Okay. Which is the reason why I said you don't have to name that person. You can say radiologist present, and that's good enough. Bottom line is, at a bare minimum, I want to understand the setting. Did you do a lateral view only, or did you add the AP view? Did you add, for example, an RAO position, a right anterior oblique position to take a look at esophageal and emptying and motility that a radiologist would comment on? All you're doing is commenting the position that you were there observing the patient. You won't necessarily offer results because that's not part of your exam. Okay. But again, these kinds of comments throughout your report are very helpful to understand what was done with the patient. In addition to that, what contrast was used? Now, obviously, we're using barium for the most part, but was it Varibar, for example? Was it Esophatrast? Was it something else in the barium family? That's really good information to have, because single contrast, double contrast, consistency, density, and so forth will change relative to the type of barium. Are you using an iodine type of contrast? So iohexol, for example, is an iodinated contrast solution. Omnipaque is another version of an iodine contrast. Some radiologists want you to use that, and the information that you gather from that is still perfectly appropriate for your exam. Okay, it's a different contrast, but you're still evaluating swallowing regardless of the contrast. So I want to put that there as well. Then, it's kind of the standard issue, if you will. What did you give the patient in what amounts, and what was that presentation? Meaning, was it by teaspoon? Was it by cup? Was it by straw? Did the patient feed themselves? Did you feed the patient? Okay, all of this information. Maybe it was the MA who fed the patient. All of this information is helpful to kind of remind you about what was going on. If the patient was fed all the time, then how do you know the patient can feed themselves? Okay. What skills do they have of hand to mouth, for example? Or are they so weak from some progressive muscular disease that they can't hold a cup, they need assistance, or the cup ends up spilling all over them as a direct result? Okay. Nobody wants to put anybody in that position, but that's good information to have. Does it have anything to do with swallowing? No. But there are implications there for other forms of rehab, for example, occupational therapy as a recommendation. From there, I want to know all about the oral phase, the pharyngeal phase, and whether there's esophageal clearance in all the different ways that we're talking about. I know that there has been a very broad education, certainly since 2008, We're talking about the MBS-IMP, or the Modified Barium Swallowing Impairment Profile. It is standardized. There are 16 components on that profile. We all are at least familiar with it if we're not using it. All of those things are certainly fodder for thought and included in my reports. I do follow the MBS-IMP. I have a very strong believer in that it is reporting the information that I need to know, no more, no less. It is the absolute framework. It is the skeleton by which everything else in my report is derived. From there, and I'll skip past that, everybody knows what I'm talking about, so we'll kind of cut time a little bit here. Moving past that, I want to know where the disorder is, okay? Not all 16 components are going to be disordered. I want to know where the disorder is, and I want to know what the interaction is between those components. How do you know that it's tongue-based retraction that's a problem, as opposed to hyolaryngeal excursion that may be contributing to that problem, for example? Okay. These are the things that are the bulk of your assessment portion of the note, if we're still talking about the SOAP note in that regard. You need to interpret it. The assessment part is not merely a verbal repetition or a verbal representation of the scores that have been given in the objective portion of the note. You need to tell me why. You need to tell me how. Those are the things, those are the very two questions, the only questions that I want to know in an assessment note. Why and how. Okay. Once that's done, now you need to think about what you're going to do about the stuff that you identified as the disorders. Okay. Is it strictly compensatory? Is it compensatory with rehab? Is it compensatory with rehab that results in you as the SLP doing your thing on one side and then further referral to another caregiver in some form, whether it's otolaryngology, neurology, gastroenterology? Maybe you have another radiological test that is necessary. Maybe you only did a lateral and AP view of the patient as the modified, but you really need to see about motility. That motility study, of course, can be done in a couple different ways. The radiological way is a barium swallow study or an esophagram, in terms of more along the lines of a GI thing. You might see motility as high resolution manometry or manometry in general. Or if you want to take a view of the esophagus, then certainly esophagoscopy or a TNE through ENT might be a possibility as well. So thinking through what the next step might be, depending on your results, depending on the finding, and I want to caution, depending on whether you think something can be done about it. Okay. I make recommendations for things that I know will have ultimate consequences in terms of whether there's an additional procedure that could fix it, a medication that can address it, a therapy that the patient can go through, additional testing that will lead to other things to truly fix the problem. I often don't refer, but I will comment on things. I'm concerned about this, but I don't believe that further assessment is necessary at this time. Okay. Don't be afraid to do that. People are welcome to disagree with you, and they may continue, down that path with regard to further assessment and so forth. But in terms of where you are in swallowing, maybe it's just not necessary, because it's not going to change your outcome, no matter what it is. Okay. So that's the plan. Now come the recommendations. And unfortunately, I think this is really some of the weakest writing that I've seen in most reports. Even though there is a phenomenal amount of time they spend teaching how to write goals, I don't often see strong goals that are measurable in swallowing notes. And that's probably a whole nother segment. But what I would say is be careful about the goals that you write. Try to make them measurable. Try to make them reach a certain standard, whether it's by percentage or by completion or whatever it may be. Maybe you want to improve tongue strength by using that bulb device kind of thing, regardless of which one you're using. I want to see a 15% increase in kilopascals of the patient in the next 4 weeks. Okay. That's a reasonable goal. Okay. It's a measurable goal. Those are the goals that are going to help patients. I want the patient to be independent in completing a supraglottic swallow so that they can do this safely, right? That's a measurable goal. Okay. I don't want to see goals like improve tongue strength, period. Improve pharyngeal strength, period. Okay. Those don't help me. I will acknowledge that there is a debate among colleagues that we're having of whether the person who gets sent for the modified barium swallow study and ends up in your facility, whether it's appropriate for you to write the goals or it's simply give the results and let the primary therapist, wherever this person came from, write the goals. Okay. My personal opinion, if you're asking or implying it, is that I should be writing those goals. I'm the one who just evaluated the patient. I know the patient well enough and what they can and can't do. I also saw the patient off camera, and I truly want to emphasize that. Whether it's fees or it's MBS, there's a lot of time spent with this person that is not recorded and not available in any recorded form. It's discussion, it's counseling, it's education, it's even trying stuff out in your clinic to see what they can and can't do. That's the stuff that's not likely to be recorded in the first place, but you will have that knowledge of what that person is capable of or what they might be capable of. Based on the results of your report, this is a critical thing to add to your report in that recommendations based on the person's cognitive abilities and neuromuscular integrity, so forth and so on. This person is capable of, or this person has the potential of, here's the goal. Okay. For me as a clinician, I've seen a lot of reports come to me that don't have specific recommendations. Certainly, I can interpret the report and I have a good idea of what's going on. Fortunately, in the electronic system now, in this era, access to the videos is more frequent. And where possible, and with no exception, I still review the video. And I make my recommendations more often based on what I see in the video when there's absent recommendations in the report. Okay. Sometimes they're in conflict with each other. The recommendations made by the SLP or whoever wrote the report is different from what's actually in the video. Mm-hmm. So part of our due diligence at all times is to review the exams that were done previously. Okay. Sometimes we only have time to review that which is written. Okay. I'm going to strongly encourage anybody that if they have access to the video, they will find the video far more interesting, far more educational than anything they will ever read, even from the best clinician. The true idea of picture of 1,000 words or picture has 1,000 words really rings true here. So where possible, I'm going to highly recommend review of the video. And then, of course, in the final parts of the note, you want to make a prognosis. Not only have you made the diagnosis of dysphagia, whether it's oropharyngeal, esophageal, or some, pick a, ICD-10 term. Okay. Prognosis is important because for somebody who has a very poor prognosis, third party payers may limit their ability to cover therapy on that patient. I'm not at all suggesting that all of our prognoses need to be good or excellent or even fair. What I'm saying is be honest, but put it in the report. Okay. Whether you choose to treat that patient or whether you choose to treat that patient and counsel the family, or whether you choose to treat the patient and, not treat the patient and counsel the family only, or you don't intend to do treatment at all, that's fine, but it needs to be justified. Part of that justification is the prognosis. Okay. And of course, what you wrote in your assessment. And then finally, sign the note. I think one of the biggest highlights that I have that's not a highlight is not in big, bold letters, the patient aspirated. Okay. In fact, the statement that I personally have in my note about laryngeal penetration and aspiration is the absolute last statement in the results. And no, I'm not a drama king and I don't do this kind of thing for purpose to kind of, all right, where is it? What did he finally say? Okay, that's not the point here. The point behind a modified barium swallow study and a FEES and any other instrumental exam is to get results, the results of the physiology of the swallow. Aspiration, I very firmly believe, and I think the field understands this, is the result of disordered physiology. It is the absolute last thing in my O section. Okay. Whether the patient aspirated, I want to know when the patient aspirated, before, during, or after the swallow. I want to know the consistencies that this occurred on and whether it was cleared and what compensatory mechanisms might have changed. The manner in which the patient took the volume also matters. Patient may have only penetrated, for example, on a teaspoon of thin liquid, but they aspirated when they were drinking from a cup. That's good information to know, and it's critical information to know. So yes, include that information too, but let's put it in its proper place. Physiology needs to be emphasized. Physiology explains laryngeal penetration and aspiration, not the other way around.
Definitely. I couldn't agree more. And I think you provided a really nice framework and outline for people who are interested in improving their reporting or maybe even just starting the process of reporting for those who are joining us for this webinar and haven't had the chance to create their own reporting framework. And I will say that I have actually done some handwritten notes in my career with the SOAP method. So I also have that experience. But with that, we'll go to our next question, which is about the downstream ramifications of reporting. So could you give us a little bit of information about the downstream ramifications of inadequate reporting?
Absolutely. So I wrote a chapter that was published in 2012, I believe, in a video fluoroscopy book. It was an international and multidisciplinary book with Peter Newman and Julie Nightingale. And I quoted actual research in this chapter. And it's actually my mantra. And it kind of goes like, although excellence in documentation does not guarantee good clinical care, it's difficult to minimize what poor documentation does for good clinical care. Okay. The whole concept here is you could be the best clinician on the face of the earth, but if you put your findings and your ideas poorly in writing, it doesn't do anybody good. Okay. Both have to be good for that goodness to be there, if you will. With that said, the downstream ramifications are kind of implicit here, right? You're done with your report. Now who's going to read it? Well, these days, good or bad, the patient has access to it. Mm-hmm. Okay. You got to be careful. You always had to be careful, but you especially have to be careful now. Okay. There's some, cultures that are a little bit more litigious than others. There are some patients who are more inquisitive than others. Okay. So having the explanation during your visit with the patient of you may read my report, and I've often said this to patients, you may read my report and think that the worst things are happening when in fact they're not. Okay. There is nothing that I have told you today that is going to be different in the report. It's just going to be in a slightly different language. Okay. That's an easy way of getting into it. And most cases, in fact, I don't think I've ever had a patient come back and question me about something I've written. Okay. So either they don't care or they understood what I wrote, in which case I've done my job. Okay. Downstream from that, you have physicians, you have nurses, you have billers and coders, you have schedulers who may look at your note for whatever reason. Certainly, you have referral sources wanting to look at your note. And in, of course, the extreme example, as I've said before, you'll have lawyers looking at your report. Okay. It needs to be clear. With conciseness often comes clarity. Don't get wordy. Okay. You don't necessarily need to be telegraphic. You need to explain, and you need to do it in understandable terms and understandable words, in a way that everybody can understand it and that it is clear to what actually happened. That's it. Those are the downstream effects, because everything else follows from that, right? What's going to happen next with the patient? Is anything going to happen next with the patient? Where does the patient go from here? Okay. All those are downstream effects, but if they don't understand your note, or you've written a novel when you should have written a novella, your note is less likely to be read in the first place. I can tell you, our practice at Cleveland Clinic, different from previous facilities, is that we actually put the diagnosis, the impression, the plan, and the recommendations at the top of the note. Everything else follows. And that starts with everything from there, starting with history, follows from there. There are even some of our clinicians who put their signature after the impressions or recommendations in the note. And then they start the history and so forth. Some may even sign it in two different places, depending on who's reading and where they're reading. Okay. The whole point here is if you want your notes read, no matter what style you care to have, you need to think about who's reading it. And primarily, it's not the patient, although they will. Primarily, it's the referral source. It's going to be your next referral. It's going to be anybody who's doing a chart review, which means that anybody who's looking at this patient's medical record. Write for them so that they understand what happened.
Definitely. I've worked at several different hospitals in the Midwest throughout my career. I've actually not seen that type of format that you mentioned that you all have at Cleveland Clinic, but I could see how that would be really effective, especially as we know, when you're another healthcare professional digging through the chart. If you open up a note and it looks extremely wordy, people don't always take the time to read it. So I could see how having those key points right at the top could be really effective. So I love that suggestion. And you kind of, in your explanation, started to get into my next question, but I'll ask it in case you have any other key points that you want to make. My next question was, what are the potential impacts on patient outcomes that reporting can have?
So, in a best case scenario, the patient gets efficient medical care, meaning no more than and no less than what they actually need to take care of the issue. In a worst case scenario, um, one of two things is going to happen. Either something's going to get missed that should have been commented on, and more to the point, should have been addressed, or you're going to, shall we say, over talk it, or make a higher priority, a mountain out of a molehill, if you will, and the person's going to get the $1 million workup. So it's a little bit of Goldilocks here. It's got to feel right, it's got to smell right, it's got to sit right with you. It's got to be appropriate, in a single word. Otherwise, there are effects of what happens. Unnecessary testing. Sometimes that testing is unnecessarily invasive. Here's a simple example of something that I've recently come across. A person was remarked that there was difficulty with motility of the esophagus. Okay. Immediately in our head was, well, it's either the barium esophagram or it's high resolution manometry to see what's going on. Person went down that road both ways. They got the esophagram for the visual. They got the high resolution manometry, right? And nothing pointed to anything. Zero, nothing. Okay. And when I take a look back on the modified barium swallow study, all I saw was a lateral view and an AP view up to C7. Okay. How is it that you suspected something wrong in the esophagus when your report had no indication of even backflow into the pharynx? Okay. These are the kinds of things that send patients down hours of testing, invasive testing. Think about what just happened with that patient alone. They were exposed to a boatload more radiography than they would have ever gotten in a modified barium swallow study. That's number one. Number two, they had to drink a boatload of barium, about 5 times the amount of what they would for a modified barium swallow study. And they had a probe that was stuck down through the LES in order to figure out what was going on. I guarantee you that there are going to be only that many people who are going to want those procedures. Okay. So what I'm saying is make appropriate recommendations based on your findings. Do not overgeneralize. Do not overinterpret your findings. You can certainly make mention of questions. Okay. We did not see anything in the oropharyngeal phase of swallowing. Swallowing is normal or safe, or however you care to term it. Yet the patient still has globus complaints, may wish to consider, would be the next term that I use. Okay. Then it's left up to the primary care physician, the referring physician, the specialty physician to make that order and decide whether they want to go down there in terms of procedures, or maybe they just simply want to start the person, for example, on anti-reflux medication, for example. Okay. These are the kinds of decisions that are the end result of our notes.
Definitely. And I think you couldn't have said it better, the importance of semantics and how we are reporting. But the other piece to that example that you gave is interpretation, right? And that's why at Tim's we're hosting these webinars and making them complimentary, because we want to make this information accessible to people, so that as a field we are having more consistency in our interpretation and in our next steps, as you touched on. So I really appreciate that example that you provided, and it just shows how, the impact that our reports and our recommendations can have, both positive and negative. In that person's case, as you mentioned, not only the invasive procedures, but the time and the money and the stress probably that patient had, thinking I've got all of these serious issues going on, and that had to be really stressful for that patient. So I appreciate that example. My next question is specifically about reporting amongst a team. You gave a great example with how you all do it at Cleveland Clinic. So as you probably know, there at some institutions is no consistency in reporting across a team. So in your opinion, what importance is there in having that consistency in reporting across the team?
So from where I stand, I kind of look at consistency in reporting as language. And I'm gonna draw the metaphor and the analogy here, okay? If you're speaking English and you only understand English, and I only understand something other than English, we're not speaking the same language. Okay. How easy is it for either of us to understand what the other person means when we're not even using the same words? Here's a simple example. Okay. I'm gonna call into focus my Midwestern roots here. Okay. I grew up with the term pop. Okay.
In the Midwest?
In the Midwest.
Okay. I'm from the Midwest and I say soda, so I love this.
Yep. And there we are. Okay. It's exactly where I was going. Out east, it's soda. In the South and Atlanta specifically, it's Coke. Mm-hmm. Okay. Can I have some pop? What's that? Okay. That'll be the first question you get. And the second question is, well, can I have a Coke? And then the next question in Atlanta is, what kind? I want a Coke. Yeah, but what kind of Coke? A regular Coke? Okay. Okay. So the point here is we're all speaking the same language, but we have different dialects. Okay. That is what's akin here when you are not standardized anywhere. You're not speaking the same dialect. It may be in the same language, but might as well not be. Okay. And even when you're in the same language, the use of terms is very different. What's flash penetration as opposed to the patient penetrated? Well, was that flash penetration? I don't understand. What are you talking about, flash penetration? I've never read that. Okay. Well, flash penetration is, oh, you mean penetration that was extricated? Okay. You could spend 20 minutes on these discussions. The whole point here is your report needs to be understandable at a bare minimum by anyone who reads it. Having things standardized by definition means that more than one person understands what's going on, because everybody is on the same page when you're talking about standardization. Okay. The whole point, one of the biggest, well, it's probably not the whole point. One of the biggest points of the MBS-IMP and why it came to be was that we weren't speaking the same language. What we said in journal articles, what we said in teaching at the academic level, what we said in chapters that were written, what we said in presentations abroad. If you were to take a look at some of the reports that came out of government, and I'm speaking about the AHRQ report that came out in 1998, there was a lot of confusion, even to the point that right now, swallowing screening when a patient comes in to an ED or a neuro unit is not a mandatory thing on the stroke pathway because we couldn't get it straight. Okay. We don't want those downstream effects, especially when we're talking about the health and subsequent consequences of health care for this patient. We need to be on the same page in terms of what we do. Likewise, we need to be on the same page in how we report it and understand it, more importantly. Standardization does that.
Definitely. Well, Dr. Brodsky, I really appreciate your expertise and time today. Do you have any closing thoughts on the topic of reporting?
The only thing I'd say is don't overthink it. Okay. As I said to you previously in this discussion, this is not a creative writing exercise. Okay. A lot of things in the electronic medical record right now can be short phrase, dot phrase, whatever they call that, right? They are standard text, if you will. If you were to put 5 or 10 or 50 of my reports side by side, chances are you would see 80%, 70% of the language is identical. Okay. Not because every one of those patients was identical, but because this isn't creative writing. Okay. This is the radiologist. This is what was given to the patient in these varying ways. These are the views that were done. This is the presentation. The patient did not or did aspirate. This is their score on the penetration aspiration scale. Penetration aspiration scale is a good one. Okay. Whether or not you like the scale is immaterial. The fact is, the verbiage doesn't change. Mm-hmm. The MBS-IMP scale, once you get past the number, the verbal explanation of that number doesn't change. It's wording that can go directly into your report, and the MBS-IMP was created for that purpose. This is not creative writing. Okay. So now the question is, let's become a little bit more mechanical to make our lives easier, make us more efficient, and to that point, spend less time documenting, but doing it well.
Definitely. Well, Dr. Brodsky, like I said, we can't thank you enough for your time and expertise today.